none other than Dr. James Johnston. And Jim, of course, is also well known because he's the medical director of the Global Surgery Program of the Children's Hospital of Alabama. And indeed, most of you will recall that with the late William Harkness, Jim spent a lot of his time on the World Neurosurgery Program. Without much ado, Jim has an amazing number of interests. He's trained at St. Louis, he's trained at Dublin, and he spent the many years of his life at Alabama Children's. And he's got a lot of interest, which includes traumatic brain injury. He's involved with amazing projects. One amazing project that I was witness to was a project on CSF. I don't know whether he's going to talk about that a little bit today. And also he's involved with a collaborative project with the School of Engineering. So he's a fascinating person with a brain that is far more developed than mine. So without much ado, I'm going to hand over to Jim to conduct the proceedings of today. Jim Johnston.
Well, thank you very much, Sandeep. As usual, an amazingly eloquent introduction that definitely outstrips my true qualities and character, but I appreciate that. It's great to see you and Nelsie, and it's a real pleasure to have been asked to help host. I think this is a very fascinating topic today. It's a challenging topic that we all pediatric neurosurgeons worldwide deal with in the appropriate management of children born typically prematurely with intraventricular hemorrhage, intraventricular hemorrhage and hydrocephalus. And I think that when you look at the accomplishments of both of our speakers today, I think that both of their viewpoints on this are going to be an important contribution to how we as a community work through this and decide what is the best management for these children. So without talking much more, I'd like to start with our first speaker, Professor Dr. Ulrich Wilhelm Thomale, who is the head of pediatric neurosurgery in the Department of Neurosurgery at the Charity Hospital in Berlin, Germany. Dr. Thomale has made many important contributions in pediatric neurosurgery and is very well known for his development and manuscripts detailing the technique of neuroendoscopic lavage for intraventricular hemorrhage, the study of neurodevelopmental outcomes following lavage and other management techniques for children with intraventricular hemorrhage. And I think was one of the most exciting things, and I hope that he talks about it a little bit today. He was absolutely instrumental in the design and implementation of the Trophy Registry with the International Federation of Neuroendoscopy, which is an international multi-center study of outcomes for children with intraventricular hemorrhage. So without further ado, Dr. Thomale, we really look forward to your thoughts today on this very interesting subject.
Thank you so much for this very kind introduction. I'm honored, and also it's a great pleasure for me to take part in this great series of webinars. And today we're talking, as you already said, about intraventricular lavage. The question, is it the best treatment for intraventricular hemorrhage in newborns, is definitely very hard to answer. I have to take the pro part of course, in this debate. And at least at the beginning, I can say yes in our setting, but maybe that's about it for this moment. For this, I want to introduce intraventricular hemorrhage and hydrocephalus, which we all know that it's a quite complicated problem for us all to be treated. The intraventricular hemorrhage and the associated parenchymal damage is the primary injury to the brain, and the secondary injury comes with a hydrocephalus, with the parenchymal damage of blood degradation, as well as the hydrocephalus itself, and the treatment complications which we are responsible for as neurosurgeons. And of course, there are the comorbidities. There's significant developmental delay, even in grade 1 or grade 2 hemorrhages, but much more significant in grade 3 and 4 hemorrhages. So the blood itself does harm to the brain. This is something what we know. The comorbidities are relevant for the outcome, which has also been introduced, and the mortality is significant. It is rated up to 40% in grade 4 hemorrhages in a publication from 2016. which was nicely described by Linda de Vries just recently in Nature Reviews of Neurology, is the secondary damage due to intraventricular hemorrhage, which is linked to any kind of inflammatory reaction, oxidative stress to the tissue, free radicals, as well as the reorganization of scar tissue within the brain itself, which causes directly developmental problems over time. And this is something we have to keep in mind. What are the options of treatment which are considered to be standard? It's the reservoir, it's the subgaleal shunt, and the external drainage. Maybe the puncture itself has been described to be more risky due to infections, and it's not very well controlled. And the study from Bativala from the American Hydrocephalus Research Network have done a meta-analysis where you can see that the infection rate is significant and actually in this meta-analysis higher in the ventricular subgaleal shunts. Arrested hydrocephalus is rated to be lower in EVDs, but reoperation rates are very high in the external ventricular drainages. So all of the options are not perfect. This is something what we know. The latest guidelines for the treatment of hydrocephalus in children also include some changes. In general, there are a lot of recommendations what should not be done. The recommendation which are basically there, that clinical judgment is necessary in order to decide between ventricular access device, external ventricular drain, ventricular subgaleal shunt, and lumbar punctures. However, lumbar punctures, in my opinion, is not the optimal choice because we are draining the external CSF spaces, but not necessarily the internal CSF spaces because there might be some blockage due to the blood. We are very pleased that also the neuroendoscopic lavage was introduced in these guidelines, which were published in December 2020. But of course, it's only a level 3 evidence because it has shown in our data that it's feasible and reduces the shunt rate. However, further data is necessary in order to make clearer conclusion. What is the basics of this intervention? It comes actually from the DRIFT study, to be honest, which was introduced by Whitelaw and colleagues, who has shown that the irrigation of blood through 2 different external ventricular drainages and also introduced some fibrinolytic agents into the ventricle, that the irrigation of blood outside the ventricles causes no significant benefit for shunted or mortality rates. It also actually increased the rate of secondary intraventricular hemorrhages. That's why the study was actually, which was a prospective randomized study, stopped. But it included 36 in the treatment arm and 34 in the treatment arm and 36 in the standard treatment. And they did, for those kind of patients which were finally included, a 2-year follow-up. And this 2-year follow-up showed that actually there were fewer deaths and severe disabilities and also lower severe cognitive disabilities, which was significantly compared to the control group. So despite the fact that the complication rate was higher, there seems to be a benefit in terms of irrigation of the blood outside the ventricle. Also, the 10-year follow-up data, which was published in 2020, showed that there's an ongoing benefit in terms of severe cognitive, of survival of patients without any severe cognitive disability. And this is drift is 66%, while control is 35%, and it was significantly different. Also, they described some health economic benefits due to this technique, which I think is very important. Dr. Johnston said that I introduced the technique. This is actually not correct because I learned it indirectly from Sergio Caballero in different talks, and we discussed heavily about it if we should introduce it. And he published his data only in an abstract in 2007 from an ISPN meeting, which was held in Liverpool. And he showed that there was benefit in 13 patients to do a so-called brainwash which was done endoscopically. 6 of the patients remained shunt-free, 7 were shunted, only 1 had an isolated 4th ventricle, and none of them had a multiloculated ventricle, and the infection rate was also quite low. So that was fascinating for me, and it took me 1 year with our neonatologists to go over this technique, especially because there was no further publication about this. We started then in 2010 with our technique, and our first brief description was in 2013, where we just described how to use endoscopy in neonates. And out of 14 patients where we used endoscopy in neonates, there were already like half of them, 7 patients, where we used neuroendoscopic lavage in order to clear the ventricles from the blood. Over 10 years period, we have seen that in neonates, the feasibility of neuroendoscopy is quite there. 14.7% of our neuroendoscopic procedures are quite stable over the years to be introduced for neonates just using the endoscope due to different reasons. But the indication of hemorrhage in patients as well as neuroendoscopic lavage is the biggest portion of all of those. And thus it becomes a significant amount of interventions in our service. Here we can look at the same period of time of 10 years. 99 patients were treated with neuroendoscopic lavage, and they had 123 lavage procedures. 89 were primarily lavage only, lavage with ETV only in 4, lavage with ventricular peritoneal shunt in cases where the protein level was still elevated, and relavage we have done, so a real relavage without anything else, only in 8 patients. So most of the patients get along with either 1 lavage alone or a second lavage with a shunt together. What is the protocol? The protocol is that, of course, we are looking for intraventricular hemorrhage, and this alone will not lead us to intervention. We always look for symptomatic hydrocephalus, and if there is ongoing symptomatic hydrocephalus, then we would indicate for neuroendoscopic lavage together with placing a ventricular access device. Then we wait and watch, and normally the situation remains calm for a couple of days, sometimes a couple of weeks or even forever. But if a symptomatic hydrocephalus reoccurs, we have the ventricular access device in order to puncture with 10 mils per kilogram body weight, and then wait until the body weight reaches the amount of 2 kilograms. The protein level should be below 2 grams per liter and normal cell counts in order to indicate for ventricular peritoneal shunting. The indication is based on symptomatic hydrocephalus, which means elevated head circumference crossing the percentiles, more than 2 millimeters per day over 1 week. Approximately, we all know this is not like a constant growth, it's just like a stepwise growth. Clinical signs, which are sometimes more difficult to interpret due to comorbidities. Ventricular dilatation measured as ultrasound indices, which should be much above the 97th percentile. And the resistance index always shows us if there is pressure inside the intracranial space. These are from our first study, our ventricular indices, where you can see we really have enlarged ventricles. We are not doing the procedure in small ventricles or if only blood is there and no hydrocephalus. The endoscopic lavage is normally one intervention. It's in a controlled environment to control infection as well as volume balance, which is very important in order not to harm the brain during the intervention by, for example, increased intracranial pressure. The access is only to the supratentorial ventricles. We normally don't do an ETV. We normally don't enter the 4th ventricle. This is the first picture you get. You have to wait until the CSF gets cleared. Then you see the clots, which are attached to the ependoma, sometimes to the choric plexus. Then you approach the clots with the outflow channel of the endoscope and gently aspirate whatever comes out, gets out, what stays needs to stay in. We don't be aggressive on this, but we try to get as much as possible, and this is feasible in most of our cases. We do a septostomy and do the same thing in the contralateral ventricle as well as in the 3rd ventricle. This is our intraoperative setup. Here you can see the monitor, which is just in front of the surgeon. This is the ultrasound, which guides us in order to puncture the ventricles. And then the endoscope, where we can use either the MINOP from Esculap or the LOTA without working sheet from Storz. Then we have the irrigation, which comes with gentle pressure by gravity through Heidelberg tubings into the endoscope itself. And then there's the second surgeon who handles the outflow channel tubing in order to aspirate either just CSF to make it flow passively or to aspirate actively the clots inside the ventricle. If we are sitting in front of the endoscope screen, we always have to think that our endoscope is just the optic, what we are seeing. What we are actually looking at the instrumental channel, the irrigation, and the outflow and the inflow channel. And these needs to be in our minds while we do the procedure. So if we have here the inflow channel in blue, this is the outflow channel in red because the blood comes out, and this is the instrumental or working channel. This is our safety channel because if this is still open during the whole procedure and some of the other channels are occluded, still the irrigation gets out and the ICP can never be higher than the length of the endoscope itself. So this is an important. During the intervention, it is looking at the site of the clots in relation to our optics. We can change the out and the inflow channel in order to approach with the outflow channel always the clots accordingly. And this is again from the very beginning, but where we approach with the ultrasound the ventricle, which is a transfontanel ultrasound. And here we use the MINOP, and here you can see the blood polluted CSF, which is aspirated right after insertion of the endoscope in the ventricle. We are using warm lactate-free Ringer solution, so it comes directly from the warming cupboard into the operation rooms, and it's heated to 37 degrees. Septostomy is done. We use normally a volume of 1,000 to 3,000 milliliters, and the OR time in 45 patients was in mean 70 minutes, and it had a range between 36 minutes and 108 minutes. This is now here what you see at the very beginning. This is the irrigation already, like 3 bags were filled, and here is the amount of outflow which goes through the suction. At the end of the procedure, we put a Bactiseal catheter, which is antibiotic impregnated ventricular catheter. It is sealed with gel foam at the proximal part, and then we put the reservoir, which is just placed on the top of the burr hole, and then we do a 3-layer suture, periosteum, subcutaneous suture, and cutaneous suture, and this is the end of the procedure. Here's basically the same, but just using the LOTA. We are not using the little LOTA because we have tried to use the little LOTA. It would be a benefit because the diameter is smaller. However, the problem is the volume exchange is not sufficient. And if we use the LOTA without the working sheet, it's actually the same diameter like the MINOP. And so both of these endoscopes can actually be used during this procedure. This is by schematic drawing how we enter the different parts of the ventricle, lateral ventricle, anterior, posterior, and the third ventricle. This is again the ventricular access device which we use, and then the sealing of the corticotomy and the 3-layer suturing in order to avoid any kind of CSF leak. This was our first patient, which was operated in 2010. It was not a preterm, it was a term baby, 41st weeks of gestation. MRI showed no clear hydrocephalus, just marginal, but clear intraventricular hemorrhage. Over the time, hydrocephalus developed with severe symptoms of bradycardia and head circumference growth. We indicated endoscopic lavage. And then here you can see the septostomy and could completely clear the ventricles. After 1.5 years almost, we took out the reservoir because no shunt was needed. So we were very lucky with our first case, and thus we were able to get like trust in the procedure itself. And this was finally our start, where we slowly integrated this as a standard procedure in our service. Of course, we have those different children, 26 weeks of gestation. Ultrasound shows large ventricles already, because it was a transferred baby, where the blood is not like a big clot anymore. Some of it was already resolved, but the clinical symptom clearly showed that the hydrocephalus is significant. We had to do something, so we cleared the ventricle by endoscopic lavage, put the ventricular catheter, which was here, put to the contralateral side, and then over the time there was a shunt necessary. And this patient was actually seen in our service just yesterday. It's now almost 10 years old. No, it's 10 years old actually, and it had another valve change after 22 months. It's less. Sorry, I cannot see that. And another one in 2017, but no other revisions of the shunts were necessary. And it's quite in a good condition. We had some gait disturbances. The patient is speaking, and is in a quite good condition, but of course needs any support in schooling because of developmental delay. But still a decent result, I would say, for this beginning. Our first publication we did on the technique showed that the shunt rate could be diminished compared to our historical cohorts from 100% to 60% or 58%, which was significant. We also could see that our infection rate went down significantly from 11.6 to 4.3%, and we had never seen multiloculated hydrocephalus in those 19 patients, and only one patient had an isolated fourth ventricle. In our extended experience, which we published together with a center in Leipzig, we introduced 46 patients, and we basically had the same shunt rate, 57.4%. And we could also evaluate in this study how much blood was actually taken out of the ventricle. So we looked at all the ultrasounds and looked how much is the amount of blood which was taken out. And we could see that, just briefly summarized, 60% of the ventricles showed less than 10% of blood after surgery. And every ventricle, lateral ventricle, was looked separately. So we are looking only at one lateral ventricle. And we could also see that only less than 10% of the ventricles had more than 30% blood left. This is an example why we leave some blood. Either it could be too much attached, or it's in our blind spot. And the blind spot is definitely the temporal horn, because we are using a rigid endoscope and we cannot get around the corner. We could see that the necessary amount of surgeries were significantly lower over time, because we had lower amount of shunt revisions if the patient needed a shunt revision. We could see a decent amount of shunt revisions in the first 36 months, which I think was quite astonishing. So it's not only avoiding the shunt, it's also avoiding the complication with the possible necessary shunt. The time point of lavage is always a big debate. As I said, ventricles need to be wide. This is the absolute precondition to make this procedure safe. But we could see that the patients who had no shunt had a little bit earlier lavage than the patients who had finally a shunt. So there might be a role of the time point, but we cannot always decide about it because there are many factors which are relevant. What about our postoperative complications? 15 from 56 patients. We had rebleedings in 5 patients. 2 were really significant. The other 3 were non-significant, and the 2 needed reoperation in terms of neuroendoscopic lavage again. Infection, 6 patients had antibiotic therapy due to any reason. 2 patients had germs in the CSF, and this translates in an infection rate of 3.5%. CSF collection was seen in 2 with no intervention, and another 3 where sutures were needed. Mortality rate was 5.4% in 3 of those patients, and 1 was actually related to neuroendoscopic lavage. So we cannot say it's an easy or uncomplicated procedure. No, it's quite an intervention, and this is needs to be done with some experience of the entire team, not only the neurosurgeon, but also the neonatologist and the anesthetists. But in general, our mortality rate was quite low. All the two others were related to comorbidities. What about our results compared to the other options? In our two centers, we had favorable results in terms of infection, arrested hydrocephalus, mortality, as well as operative revision. But of course, this needs to be confirmed in a bigger setting. Other publications have come out from Turkey with basically the same results, 60% shunt rate, lower infection rate. And also from Spain and Sevilla, and they could see that actually the infection rate in their series was increasing if they did relavage, which they did more significantly or more often than we have done in our experience. The same groups from Sevilla just published in Pediatric Neurosurgery that the shunt rate was actually at the beginning of their intervention in the learning curve was much higher than in the second, third, and fourth year, where they stabilized at a shunt rate of also like 56%, which is a very stable result throughout most of the series. How do the brain look like? Of course, we want to know what is the outcome of the patients, and we have a quite variety of brain volume development. We looked at this by measurements, and you can see here that some patients are quite normal in brain development. These were all done like 12 to 24 months after surgery. But of course, we see also some patients with quite enlarged ventricles and smaller amount of brain. The neurodevelopmental evaluation after 2 years were directly compared to the DRIFT study. And we can see that the Bayley's developmental index score showed actually very similar results after neuroendoscopic lavage in our cohort compared to the DRIFT cohort, which was published after 2 years. However, in the gait functionalities, we could see, which we measured in the gross motor functional classification scale, that we had quite a large number of patients which had no cerebral palsy or minor problems in terms of spasticity. And these numbers were much higher in the DRIFT study. So I don't know what is this relating to, but this is something we could directly compare. Of course, these results need to be interpreted cautiously because these are only comparing two different studies. We could see what kind of factors were relevant for the neurodevelopmental outcomes in terms of motor as well as Bayley developmental. And there we see that anti-epileptic drugs, which were necessary in 26% after 2 years. And we could also see that the better Bayley scores showed lower amount of anti-epileptic drugs. Comorbidities played a very significant role as well as the cerebellar atrophy or the isolated fourth ventricle. These were the most relevant ones. Gestational age plays a role, but is not as relevant in terms of factor, how it counts in. We also looked at the brain volume directly correlates to the Bayley score as well as to the motor functional score, which was interesting. So we will further look at the brain volume development. It was already mentioned that we started the trophy registry study in order to find out more about how to treat intraventricular hemorrhage and hydrocephalus more perfectly, because there's still quite a heterogeneity of protocols around the world and within the countries. And the study includes neuroendoscopic lavage, EVD, ventricular access device, and ventricular subgaleal shunt. And we look for clinical complications as well as outcome in terms of shunt rate and revision rate, and then neurocognitive outcome in terms of GMFCS or hydrocephalus outcome questionnaire after 3 and 5 years. We have started this quite a while ago, and already 62 centers from the date April 2021 were registered, 29 active centers, and 119 patients included from all over the world. And please remember trophy-registry.org if you are also interested to join this collaborative study. In summary, I would like to show this table, which was now published in 2021 by Andrew Whitelaw, comparing the general techniques in terms of continuous drainage, reliable percutaneous tapping, enhanced infection control, internalized hardware, and can be managed outside neuroscience center, yes or no. And here we can say it can be managed if we transfer the patient. All others are a clear yes. But we would say in terms of the other techniques, the neuroendoscopic lavage has the active blood removal, which is the major benefit if the techniques can be applied safely to the patient. And this is our big plus why we choose to do it as a standard technique in our service. Thank you very much for your attention, and I'm looking forward to the discussions and the further talk, of course.
Well, thank you very much, Ulrich. That is an incredible body of work that you and others have been able to put together to evaluate this technique. Our next speaker, Dr. Alison Wray. Professor Alison Wray is the Director of Neurosurgery at the Royal Children's Hospital in Melbourne. She is a native of New Zealand, did all of her training through the Australasian College and Neurosurgical Society, and has a very busy practice that includes the entire gamut of pediatric neurosurgery, including neuro-oncology, epilepsy, movement disorders, craniofacial surgery, congenital disorders, and vascular neurosurgery. Thank you, Dr. Wray, for being with us today.
Thank you very much for that introduction and for the fantastic presentation that we've just all enjoyed listening to. So I am tasked with providing evidence as to why lavage is not yet the best treatment for intraventricular hemorrhage in newborns. If we think about the spectrum of hemorrhage that we deal with, it includes a number of underlying pathologies, but mostly what we're referring to in this setting is the preterm intraventricular hemorrhages and the dilemmas about managing those. You can see on the left there are a number of risk factors that are associated with those. And if we look at the last 30 years of literature around preterm intraventricular hemorrhage, you see that there are a number of themes that pop up if you look at this topic map. And a lot of those relate to the changes in the cerebral autoregulation in the immature brain, the immature germinal matrix, but also the developing concepts of what we can do in terms of neuroprotection. And the role of surgery is really quite small in terms of the publications that have been in this arena over the last 30 years. It's important to think not only how do we treat intraventricular hemorrhage, but what we can actually do to prevent it. And our neonatal colleagues have done quite a lot of work showing the benefit of antenatal maternal steroid administration for those mothers that have been on phenobarbital or phenytoin, giving antenatal maternal vitamin K. Magnesium, both in the antenatal and in the neonatal setting, has shown benefit. And there's also been benefit shown in reducing it by changing the way in that we ventilate the children. There's also a body of literature that is evolving around the cerebral autoregulation and the way that we manage blood flow through the brain. And there's an interesting paper published last year, a Cochrane review, that showed just by maintaining the midline neutral head position with good jugular venous outflow, you can significantly reduce the risk of developing intraventricular hemorrhage in a prem neonate. There's a number of other factors that people have looked at, and for some time there was a lot of excitement about delayed umbilical cord clamping and the practice of umbilical cord milking. But again, a meta-analysis of that produced last year shows that probably umbilical cord milking does not increase the incidence of it. However, in the very premature babies, it will increase the frequency of severe intraventricular hemorrhage, and so probably should be avoided. Also, it's important that we don't forget the basics. And this was one of a number of interesting studies that have shown that if you pay attention to the neurodevelopmental handling of children in the nurseries, such as in this study, you're able to reduce the incidence of intraventricular hemorrhage in the premature children by about half. So from 21.3% down to 10.9%. And in addition to that, those that did get a hemorrhage, there was a reduction in the grade and severity of the hemorrhage. So whilst we can't prevent all of the hemorrhages occurring, part of our intervention is based upon the pathophysiology of what happens after the hemorrhage. And that for surgeons, that really breaks down to two processes. The first is the post-hemorrhagic hydrocephalus, which was the obvious target of most of our earlier interventions for hemorrhage. The hydrocephalus occurs for a number of reasons. There's the physical obstruction to flow from the clot that occludes the pathways. There's also the obliterative arachnoiditis that causes failure of reabsorption of CSF. But as well as that, we're starting to understand that there is an inflammatory mediated hypersecretion of CSF that can occur in response to the blood products within the brain. Probably more importantly in terms of neurodevelopmental outcomes is the white matter injury that occurs in response to the bleed. And this is perhaps where more of our interventions are targeting now in our contemporary management. Both the iron and the heme from hemoglobin can set off inflammatory cascades, release of cytokines and other growth factors and inflammatory molecules that can have negative effects, particularly on the oligodendrocyte precursor cells. And it's thought that this is what underlies most of the neurodevelopmental problems associated with intraventricular hemorrhage in premature children. If we think about what we're trying to achieve with the outcomes, in terms of hydrocephalus, we know from the Elvis trial that early intervention is associated with less disability than late intervention. And it's interesting that in the earlier epochs of managing this, the need for a shunt was historically the primary endpoint in most of our outcome assessments. And pleasingly, this has changed over the last decade. In fact, we're now looking more at what happens in terms of the neurodevelopmental outcome. In 2013, Kalisi's group showed that intraventricular hemorrhage outcome did not differ between groups classified on birth weight, which really indicated that the hemorrhage itself is a significant independent risk factor for neurodevelopmental disability. In a population cohort of children born before 31 weeks in Nova Scotia, they saw that hydrocephalus and CSF shunting were not associated with poorer outcomes when controlled for intraventricular hemorrhage grade, suggesting that, again, more of the disability comes from the inflammatory processes stemming from the hemorrhage rather than from the mechanical effects of the hydrocephalus itself. So when we think about management, are there things that we can do medically to help with it? And indeed there are. We've shown that magnesium and steroids can both help with outcome following hemorrhage. There are ventilation protocols. And people have even looked in the post-hemorrhagic ventricular dilatation drug trial at the concept of reducing CSF production with acetazolamide and furosemide. However, this study had to be stopped early as there were worse outcomes in the treatment group. So this is probably not a fruitful area for further research. In terms of surgical treatments, you can see running down the left-hand side there that there are a number of acronyms of things that have been tried and things that are still being used. And whenever we're in a situation where there are so many surgical options, it suggests that we really haven't found the best one yet. As you'll see, these run from more historical to more contemporary, and there's a change in philosophy moving from simply managing the hydrocephalus to trying to manage the blood clot and the inflammatory process that occurs as a result of that, as addressed with the concept of moving towards fibrinolysis or lavage of the ventricles. So if we look at CSF tapping or CSF removal, really introduced to try and limit the progressive ventricular dilatation, and many of the studies looking at the outcomes of this have used concepts such as the need for a shunt as their outcome measure. The CSF tapping and removal will remove some of the blood and inflammatory products, but certainly nothing to the degree that we see with the fibrinolysis or lavage. Most of the time when we initiate CSF tapping and removal, it's with a treatment paradigm that's around temporizing until either the CSF circulation reestablishes or until the child is physiologically able to have a shunt placed. There's not a lot of data looking at the options for tapping, but there was a Cochrane review published in 2017, which looked at repeated lumbar or ventricular punches in newborns, and unfortunately found that there was no evidence that repeated removal of CSF had any benefit over conservative managements in neonates at risk of developing post-hemorrhagic hydrocephalus, either in terms of reduction of disability, death, or in need of placement for a permanent shunt. However, I would have to say that at this point, there was actually limited data looking at outcomes other than placement of shunt to go into this Cochrane review. You've seen this nice infographic already today. And I put this in really to illustrate the conceptual process that most of us go through when we're thinking about the options of managing a child with an intraventricular hemorrhage, and really how we relate it to the resources and the skills that we have and how we're going to manage the child. There's more of a tendency in a resourced situation to go for a ventricular access device or a ventricular subgaleal shunt, as it allows ability to have repeated tapping, has a better infection profile, is internalized, and can be managed outside a quaternary center. In terms of the external ventricular drains, obviously there are a number of technical issues in terms of placing these and managing these in small prem children. And so there are a number of groups who have had success in modifying the technique to a more age and size appropriate. And this is just one paper that shows the percutaneous tunnel technique adapted for very small young children. It does, however, negate some of the neurodisability measures that we know also have benefit in improving outcome. So we know that measures such as kangaroo care, skin-to-skin contact also have a very positive outcome on long-term disability, and placing external ventricular drains does significantly impact upon the handling of the infants and the ability to do these sorts of cares in the nursery. So another review paper looking at the two most commonly used devices for intermittent tapping of CSF, that of the ventricular access device and the ventricular subgaleal shunts. And the difficulty in trying to review the literature on this is that there hasn't been any standardized criteria, and the cohorts between all the studies have been very heterogeneous. Pulling it together, however, there's no data to suggest superiority between one or other device. However, the authors did note that many centers may find the fact that you have reduced rates of tappings with the ventricular subgaleal shunts to be more attractive in their settings. So then we move on to the first of the more contemporary management concepts, really looking to address the inflammatory cascade that occurs after a bleed. And that is the DRIFT trial that you've already heard about this evening. So the DRIFT trial was undertaken in 4 European centres between 2003 and 2006, and they enrolled 77 babies, 69 of whom survived until 2 years of age. The study was terminated early, not because there were problems in the treatment arm, but it was because it became clear that they wouldn't meet their primary outcome difference, because the primary outcomes was set for the study was in shunt rates. When they did get to 2 years and they analysed one of their secondary outcomes, they found that there was a significant risk reduction in death and severe cognitive disability within the treatment group. It did, however, as I mentioned before, did not reduce the need for a shunt and thus failed to meet its primary treatment outcome. It was also identified that there was a significant increase in secondary bleeds, most likely as a result of the fibrinolysis that was used. However, if we look at all the contemporary studies in a meta-analysis of post-hemorrhagic ventricular dilatation, the drift to date was probably the most efficacious in controlling this. There has, however, been quite poor uptake, and that's something I'll get to in one of my subsequent slides. And the reason for that poor uptake, I think, was addressed by the authors in their second long-term study, where they identified that the insertion of the catheters, the prolonged and accurate ICP monitoring required, and the adjustment of drainage rates with detection of catheter blockage and what they referred to as immaculate aseptic technique provided a complexity, risk, and rarity which they felt was comparable to putting the child through ECMO. So their recommendation was that this was for specialised services centres only. As mentioned before, the investigators re-looked at their children at 10 years, at which stage they had 28 in the treatment arm and 24 in the non-treatment arm, or the conservatively managed arm, that they were able to review. They found that the cognitive effects held over the 10 years with less cognitive disability, and the children were more likely to be in mainstream school. They found that it didn't improve motor function, a concept that we've heard introduced just before, but there was also a trend towards improved visual function. And that brings us to the next and contemporary concept, the iteration and improvement on from the drift trial, which is neuroendoscopic lavage. And this has been very well described in the last talk. And so we'll probably skip over these slides, as this has been much more eloquently described to you. The difficulty, though, is that this is still a relatively new technique and the data is still coming through. So to date, there are no prospective comparative trials. There is, as pointed out, one group that has done some neurocognitive outcomes, and so they have assessed it 2 years. At this point, 61% of their cohorts were assessed, and they were found that 30% had cognitive profiles within the normal range. The Great Ormond Street Hospital is currently midway through their Enliven trial, and that will also give us outcomes both in terms of, in terms of shunting and neurodevelopmental outcomes at 2 years. And as alluded to before, neuroendoscopic lavage is not just a single intervention, and many of the groups talk about the need for a second lavage, and if requiring a repeated TAPS, the use of a ventricular access device. And now a lot of the larger units have protocols with implantation of either a ventricular access device or an EVD at the time of primary lavage. So whilst it is promising and obviously in expert hands looks as if this may be the way forward, the current evidence would suggest that it is not the best treatment. And going strictly on published class 2 and 3 evidence, because we have no class 1 evidence, it would suggest that the drift protocol was probably our current standard. However, there's been very limited real world uptake and significant implementation constraints with that protocol. As mentioned before, the Trophy Registry possibly offers us the best way to compare head-to-head the various ways and to get the data and information that we need to find out what of our current surgical techniques is going to have the best both neurodevelopmental outcomes and shunt avoidance. Probably more importantly in the future is that the burgeoning amount of research around the biomarkers looking at the inflammatory processes in the white matter injury will be able to be incorporated into some of these outcome studies. So what is our ideal treatment? Well, obviously prevention would be the holy grail. We must acknowledge also that our neonatal colleagues have been doing quite well with this over the last couple of decades. Our ideal treatment would be minimally invasive, and it would also include neuroprotection strategies to work on some of the medical cascades that are occurring at the same time. The treatment will address ventricular dilatation, but more importantly, it will address the inflammatory and toxic cascades that occur and cause the white matter injury, and possibly in the future may be tailored to the biomarkers so that we may be able to identify and see when children need more lavage or more intervention based upon what their biomarkers are doing. You've seen this diagram tonight from the De Vries group, who looked at the mechanisms of white matter injury in this setting. And you can see that there are a number of pathways that are associated with the development of the white matter injury, and that the surgical mechanism-based treatments are really just a small proportion of the things that we should be incorporating into the ideal care for these children. But as well as tailoring to biomarkers and incorporating those, we're also entering the era of omics. And so they've also identified that there is a lot of work around the injury that's happening to the oligodendrocyte precursor cells, and that may underlie a lot of what happens, particularly in the motor disability associated with this. There are a number of possible targets for targeted therapy associated with this, and also the potential for stem cell treatment to try and replace some of these cells has been identified. But as we are an international group practicing across the globe with a variety of different resources, I think really the ideal treatment also has to be appropriate to the resources and to the skills that we have available within our healthcare settings. And I'd just like to thank the ISPN for the opportunity to go over this with you this evening. Thank you.
Thank you very much, Dr. Wray. It's an excellent presentation, and I think brings up a lot of the questions that many of us have in the back of our minds about lavage. I mean, obviously, I think that from what Dr. Thomale has presented, there's a lot of, it's a very logical concept of being able to remove blood from the ventricles to avoid some of the cytotoxicity that you've talked about in your speech. I've noticed that some of the questions that have come up in the chat have kind of revolved around some of the technical aspects of the procedure, Dr. Thomale. And I think that for myself, as well as being, I do a lot of neuroendoscopy, but to do neuroendoscopy in such small infants, especially when the spinal, CSF is bloody, et cetera, I really think that this definitely is a technically demanding procedure. And a couple of the questions that were brought up were the use of flexible endoscopy, and at what age or what size of the infant you have found it to be safest to be going in. And obviously you have a lot of experience in this, but what kind of advice would you give us, Dr. Thomale, for those of us who have not done a lot of this procedure about, the best candidates and how you go about evaluating a patient and deciding whether they're a good candidate or not?
Yeah, I think the experience with neuroendoscopy and slowly increasing experience in neonates with neuroendoscopy is an absolute precondition. And this, as I said, does not mean it's not only important for the neurosurgeon, but it's really for the entire team. And it's depending on the infrastructure of the center where you're working. So in our center, our NICU is located on the same level as the operation rooms. So they basically have to just transfer the baby from this level over, let's say, 20 meters into the operation room, and then we can perform the procedure, which is a big advantage, I would say. If this condition is not there, it's already a much bigger risk for these small individuals. The other thing is that when and how to start. It's maybe not the good choice to start with a simple intraventricular hemorrhage with hydrocephalus if you don't have the experience. But where we started with was actually the intraventricular infections. So due to any reasons, if there were some ventriculitis, we have done our first interventions, I think, during early 2010 or even 2009, in order to try how the technique works. Because in those individuals, you're much more in a situation which really needs help, because antibiotics will not help the patient in a fast way, and to get out the bacterial material out of the ventricles even more relevant than only the blood in pure IVH patients. So these were the first cases where we tried, is that feasible, is it safe, can we do it in our infrastructure and also experience conditions. The other thing which was mentioned in the chat, and you also mentioned it, is the flexible endoscope. Of course, it would make a lot of sense to use a flexible endoscope, and it has now been used much more since choroid plexus coagulation is quite a standard techniques in some centers, which is not in ours, I have to admit. And we are not using flexible endoscopes at all, because we would need to borrow it from our urologists, because the neuroendoscope is, there's no licensed flexible neuroendoscope in Germany. Even if it's produced by Storz, it's not licensed for neurosurgery. So we are not able to buy it. And it's, to be honest, not legal to borrow it for the urologist, which was done maybe in the early times of neuroendoscopy, but nowadays it's not the same story anymore. And also it has only one channel. I know that Christian Aquilina is using the flexible endoscope as well in the Leven study. You have only one channel, so you have to do the irrigation and the aspiration and everything else through one channel of the flexible endoscope. And the vision is, I think, also a little bit less. So you have advantages and disadvantages. Of course, to handle the flexible endoscope is a different story compared to handling a rigid endoscope, which may add further risk to the procedure. But this depends, again, on the experience on the neuroendoscopist.
And Dr. Wray, just based on maybe as a place to start, how is intraventricular hemorrhage in neonates handled at your institution? And maybe how has it changed, or where do you see it going, I guess, with some of these developments you mentioned in your talk, and what do you foresee in the future as ways that we're going to better manage these children?
So we're quite traditional. We tend to use a ventricular access device. There has been quite a change with our neonatal colleagues as they've got more confident about their ability to reduce the incidence. And certainly over the last 15 years, the incidence has reduced in our population. They're also being more proactive with steroids and magnesium and the way that the children are handled. So they are confident on the medical side as well as what we're doing from the surgical side. I think I'm certainly interested in the concept of lavage and see how that plays out as we understand a little bit more, particularly if we can track it with biomarkers and work out when we should be intervening. But the difficulty becomes that as the incidence is going down in a smaller population, is it appropriate to be doing small volumes when you might only be seeing a couple a year? So it may be more appropriate for us to continue with other ways of doing that. The one thing that we do seem to do differently is that we will tap for longer. So we will not shunt until they get closer to 3 kilograms. And we find that our shunt rate is actually a lot lower than when we were shunting them at 2 kilograms. So by holding out until they get to 3 kilograms, we're achieving shunt independence in a lot more children without seemingly increasing our infection rates.
So I guess the question may be open for both of y'all, and Dr. Thomale mentioned your thoughts as well, is, you know, with the trophy registry, et cetera, what in 5 years from now, what would be the ideal, you know, if you give this talk now 5 years from now, what kind of data would you want to have from how many centers and how many patients, et cetera, to basically best answer this question? And you, Dr. Wray, what kind of information do you think we have to have? You mentioned biomarkers that would definitively be able to tell us yes or no, this is a great procedure, and for what patients it's indicated for.
Yeah. So from my side, I think the most important thing is to be more aware of the whole disease, because the biggest problem is, if we look at the data for a long time, if we look at guidelines or if we look at surveys, people are approaching this disease differently without maybe any protocol. There are only a few people who are actually addressing protocols in the center and trying to do some research in order to push the envelope. But these are only a limited amount of people. And even though if the amount of patients are going down, it's not going down in a lot of centers all around the world, to be honest, because there's still, this is a significant number of patients with hydrocephalus we have to deal with through their whole life, because they are shunted, they are not necessarily dying, These are chronic patients which we have to care of. So the awareness of the disease and what we can achieve is, I think, one of the most important aspects at this point. And it's not necessarily that everybody does neuroendoscopic lavage, but to think about what the disease is causing over a long time, and what we as pediatric neurosurgeons are actually able to change for the families and individuals. I think this is one thing we need to address at the first step. And for everything else, I mean, the trophy study will not end up making guidelines for this disease, but it will contribute in this direction. And how far it will contribute, it depends on how much data we put in such a registry. It's an open registry, everybody can enter the data, and we will, at least at the end, if we fulfill our protocol aims in terms of numbers, we will analyze the completed data as it was entered inside. And it depends who is active and who is really interested in this disease to change something for it. So this is basically it, and we will see how it goes. At the moment, I think we're doing very good, but we have to keep up. That's important.
So I think you mentioned a question about what we would like to see in terms of biomarkers. One of the things that I think there is some interest about is looking at the heterogeneity of outcomes and whether there is actually genetic vulnerability, whether we can identify some children who are more likely to be vulnerable and may need a more aggressive approach, in addition to identifying what cascades are starting to be triggered, again, as a marker of when we might need to be more aggressive with our approach.
Well, thank you both very much. I think this has been, I know I've learned a lot and seeing, and I've spent a lot of time, we take care of a lot of children with intraventricular hemorrhage and prematurity here in Birmingham. And I know that I've learned a lot just listening to both of you today. And I think that this is a very important topic that I think will hopefully generate a lot of interest from all of our members and people who are listening to contribute to this effort, with signing up for the Trophy Registry and working with their neonatologists to improve care with children with intraventricular hemorrhage. So with that, Sandeep, I don't see any other, there's...
If I may ask a question, two short, small questions. One, of course, is to Ulrich, which is how much fluid, what is the average volume of fluid you use for a lavage in somebody who's got a intraventricular hemorrhage? What sort of average volume of Ringer solution do you pour in?
So normally it's about, the average amount of volume is 2 to 2.5 liters. It can go up to 3. In very rare cases, we have used 4. In infection, we have used more than 4, actually, because infection is a more complicated situation and you have more things to get out of the ventricles. In only less amount, we have also used in some cases only 1 liter, but this is the range. So normally between 1 and 3 liters is something which we use. And it's not the amount of volume, it's the question of the volume balance during the irrigation. This is the most important thing to keep the whole procedure safe, because it always looks or sounds maybe frightening if I say we use 3 liters in a 1 kilo baby, but on the other hand, it's just going in and out at the same time. So it's not more volume to increase the intracranial pressure. That's very important to say.
And one other question about infections. How do you think this procedure rates in infections as compared to intraventricular hemorrhage? Would you recommend it for infections with ventriculitis? Do you think it stops multiloculated hydrocephalus from developing if we do this? As you know, there's some work that has been done in Asia and Malaysia, particularly looking at irrigation for post-infective hydrocephalus. I know you don't see very many in Germany as we see in this part of the world, but still, do you think it's a good procedure, and how does it compare with lavage for hemorrhage?
Yeah, it's definitely very important for ventriculitis. And even if we don't see a lot, we see those patients. And if we see them, we have a problem. And lavage is a good solution, at least to make this problem a smaller one. Because you don't have to put an EVD and put systemic antibiotics for weeks and weeks and weeks until the situation stabilizes and the brain basically melts away. You can do the intervention and get a much earlier stable situation. In those, you need to do lavage more often, so you have to repeat it. But you can actually reduce the amount of true multiloculated hydrocephalus. That's a very beneficial effort which you can get by neuroendoscopic lavage. That's why I really recommend, as I said earlier, to start with ventriculitis, because these are patients you can only do better because they are already in a very problematic situation. And then if you feel comfortable enough, then you go to IVH, because there are still alternatives which are safe and which are published in literature, and you really have to convince the whole team that such an intervention is reliably be done and safely be done by your team, because otherwise everybody else will say, no, we stopped the protocol, you should not do it. So we are very much controlled by the neonatologists, and that's why safety is one of the most important issues.
And one question to Alison. You use a ventricular access device for your intraventricular hemorrhage. When do you decide you want to tap that ventricular access device? Is it based on clinical profile, head circumference, or ultrasound imaging? When do you decide you want to tap that?
So generally when I put one in, I start off with a 10 mils per kilo per day tapping protocol, and then follow with ultrasounds. I found that head circumferences are not reliable because of the fact that the brain is so watery at that age and will easily compress without putting the head circumference up. So we will frequently ultrasound them and then adjust the frequency of tapping depending on how the ventricles are responding.
So if I may ask Jim himself to tell us, what's the protocol you follow in UAB?
Yeah, so UAB, we primarily do ventricular subgaleal shunts, our subgaleal shunts typically are put in with a reservoir. So if the pocket resorbs, we can tap it like a reservoir, and we follow a similar protocol to what Dr. Wray said in those cases. We tend to wait till about 2 kilograms before putting in a shunt. We do a lot of neuroendoscopy, but we don't do lavage, just because, we take care of a lot of really preterm babies, like 23 week, 24 week, very small, a lot of medical comorbidities, and trips to the operating room can be challenging just from a medical standpoint. One question I had for Dr. Thomale with the irrigation, are there ever any issues with electrolyte disturbances or anything with the amount of, replacement of cerebrospinal fluid that you're doing, and it sounds like about 26 weeks is about where you do it, about 3 weeks, at least around 3 weeks of age and 26 weeks gestation. Is that where you tend to start, or what would you suggest in that arena?
Actually, our youngest was 26 weeks of gestation, but this was very young child. Normally, our median body weight, we always look at the body weight because this translates more in the stability of the patient itself, is 1.5 kilogram. And normally we do it between 10 and 18 days after hemorrhage. So it's not done immediately. So it will take like 2 weeks after hemorrhage is normally the time for it. But sometimes later, it depends if we get a referral, yes or no. The question, what was the other question? Sorry.
I also with access, I noticed you always go from frontal.
Yeah.
Have you ever tried occipital, or have any other groups tried occipital approach for this?
Yeah, no, we always use frontal. We have discussed in another talk I had a couple of weeks ago, and that was actually the question, why don't you go occipital? Because then you can reach the frontal horn and the temporal horn as well. But I think the whole situation in the operation room is even more unstable to place the child in the proper way, do the septostomy, and also get to the contralateral ventricle is much, much more difficult. So we stay frontal, and we will keep it like this. We will not go occipital.
Let's see, there's one question I think we can sneak in here. I guess there was one question about why you don't do an ETV at the time that you do the endoscopy. And you mentioned because of concerns that it just closes up and risk. Have you done much ETV work in intraventricular hemorrhage children, and what's been your experience with that?
Yeah, out of those 99 patients, which we did in 10 years, we have done 4 ETVs together with Lavage. And those 4 were the ones where we did not find really high proteins levels and only few amount of blood anymore. And then we desperately say we have to do something good, because we say it's not changing anything if we do only the Lavage. And then we did the ETV. So, that's an individual decision making. Generally, we recommend not to do an ETV, and that comes from the very beginning, because we said, again, safety first. The question is, does it help? We consider ETV at this age to close right away and will not help for long, maybe just for a couple of weeks. And why adding further risk to the prepontine cistern, where all the very small perforators from the basilar artery are entering into the brainstem? We said it's just not necessary to do it. That's why we did not do it from the very beginning, and we kept it the same way.
All right. Well, thank you both very much. It's been a fantastic discussion today. Sandeep, I'll let you close things out. It's been a pleasure talking with everyone in the ISPN. Thank you.
Thank you very much, Jim. And I'd like to thank our speakers, Ulrich and I think Alison, both of whom did a fantastic job. And I want to tell you that today's been a very unique day. I mean, it's unique in many ways today, by the way, because it's the 21st day in the 21st week of the 21st year of the 21st century, if you haven't noticed. But apart from that, this day is unique because we have the single largest number of audience for a Clash of the Titans in the last 6 months today. So I think that the moderator and the chair and the 2 speakers deserve a lot of congratulations. So thank you very, very much. It's been a record in many ways. Just to wind up and say thank you very much to the audience who checked in for this Clash of the Titans. The next Clash of the Titans is slated for 18th of June, Friday, the 18th of June. And because we have a number of courses coming up in July, we will limit our Clash of the Titans to 1 in the month of June. So wherever you are, in whichever part of the world, have a great day, good evening, good morning, or good afternoon. Take care, be safe, and we'll see you on the 18th of June.